Hello everyone, my name is Pat Huckabee and I'm the Senior Ambassador at Monarch Healthcare. Monarch Healthcare is a large medical group of over 2,000 physicians. We are the primary care doctors and specialists that partner with your HMO plans. I represent most of the doctors who take care of you. As Senior Ambassador, I can help you to resolve any special situations you may encounter. For instance, you may have an appointment to see a specialist and you find that you can't get in as soon as you would like. You could call me and I can see if maybe I can find someone else to see you sooner. Today we're going to be talking about a topic which is really something that all of us seniors should really be very aware of, and I'm very glad that we were able to have one of our Monarch specialists here today, and I'm sure that this is going to help you when you're going for your annual vision check. Our topic is macular degeneration, so a lot of you will identify with that. And our guest is Dr. Charles Eifrig with the Retina Associates of California. And so welcome, Dr. Eifrig.
Thank you.
Very good to have you here. And I know your office is very close, so you can tell us where that is.
It is, yes.
Yeah.
So we do have 3 offices, but our main office is in Laguna Hills in the Taj Mahal building,
right.
At El Toro right there.
Yeah, so that's really good for all of us to know, because, well, as we talk later, there might be occasions where we have to go there frequently.
Yes, yeah, unfortunately, yes.
That would be very good to have it convenient. And so tell us a little bit about your background, and of course you told us that you've got 3 locations.
Yes.
And what is your background?
Yeah, so first of all, our group, the Retina Associates of Orange County, has 4 doctors, and we're retina specialists only, so we deal with just retinal conditions. My personal background is I'm originally from Minnesota and been all over the United States, went to medical school in North Carolina, and then did my retina training, ophthalmology residency training in a place called Bascom Palmer Eye Institute in Miami, Florida. And have been now here in Southern California for about 8 years.
Wow. Good. People get around. I think
yeah, in the medical field, yes, absolutely.
They get around,
yes.
Go to all different places.
Yes.
Well, that's great. It gives you a lot of insight about other parts of the country
I think
and everything,
so, yeah.
right? Yeah. So, well, what kind of eye problems do you treat then, a retina specialist?
Yeah, so as a retina specialist, the most common 2 conditions that we take care of are diabetes and macular degeneration. And ironically, with the geographic locations of our offices and the demographics that are different than our 3 offices.
That's true.
The Laguna Hills office by far and away has the patient population that we deal with most are patients with macular degeneration.
Yeah.
And our Santa Ana office, because of the Hispanic population, which has a higher incidence of diabetes, that most commonly we deal with diabetes up in the Santa Ana office. So diabetes and macular degeneration are the 2 most common diseases we take care of as retina specialists. And then there's a lot of other conditions that we deal with, whether it be complications of cataract surgery, which is rare but can happen. We deal with lots of vascular diseases that affect the retina as well that are a little bit different than diabetes or macular degeneration. We deal with trauma, we deal with infections, and we deal with inflammatory conditions of the retina. And then surgical problems like retinal detachments and macular holes and lots of emergencies with retinal tears and retinal detachments, but certainly macular degeneration is, as our population is aging, is the most common condition that I see every day.
Yeah. So, wow, you can really see that it has to be a specialty then.
Yes.
Yeah.
It really does.
Is,
It's one of those things, the more you know about the eye, the more you realize there is to know.
Yeah.
And the retina, the more you know about the retina, the more you realize there is to know about the retina. And it's a very complex organ, and it's why we have so many specialties within ophthalmology.
Yeah, that's really something. Yeah, so Well, what is it? What is macular degeneration?
Yeah.
Since that's going to be our topic.
Yeah, so macular degeneration, as the name implies,
Right.
it affects the macula, and the macula is just the center part
Let's
of
see.
the retina. Oh,
I
yeah.
think we're at our, yeah, there we go.
Great, yeah. So, the macula is the very center part of the retina. The retina, I tell patients, if you think of the eye like a camera, the retina is basically the film of the camera. So the macula is the very, very center of that film, is the very center of the retina, and it's really what allows us to have very fine, acute vision centrally. Degeneration, as the name implies, is a condition that tends to get worse over time. So this is a disease that affects the center part of your retina, the macula, and unfortunately tends to get worse over time with or without treatment. And there's basically two types of the disease with macular degeneration, which we may go into later on, but I can talk about it now. There's the what we call the dry type and the wet type. The far majority of patients have the dry type, and it's about 80 to 90% of patients have the dry type. About 10 to 20% have the wet type. Unfortunately, the patients that have severe vision loss, though, are more likely to have the wet type. So although wet is less common, when it does occur, it's more likely to cause severe vision loss. The interesting aspects of the disease, unlike glaucoma that may affect your peripheral vision, this does mainly affect your central vision, and it is, once again, most common in people over the age of 50.
Yeah. Does laying out in the sun, you know, I'm always thinking about that with California and people and kids doing that. Does that have anything?
So ultraviolet light has been shown to be a risk factor in the disease.
It is. Yeah, it could be. Yeah, I always think about that because people really are so conscious. I mean, as they get older, I think of wearing sunglasses and protecting their eyes.
As kids, we didn't.
But
really,
the kids,
no.
they still don't. That happens with a lot of things.
Right. Yes.
Yeah.
Exactly.
So, okay, then let's talk about what causes it. We have our slide up there. What causes it?
Yeah. So the cause, despite all the information we have and all the research we have in macular degeneration, we still don't know the exact cause. But it is multifactorial. There's lots of factors that cause this disease. Lots of risk factors. About 50% of the time we feel there's a strong genetic cause, if you will. There's genetics here that play a role in this disease without question. And then there's risk factors. So the number one risk factor is age. So the older you are, the more likely you'll get this condition. We rarely see this condition under the age of 50. So this is a condition almost always seen over the age of 50. Other risk factors include modifiable risk factor like smoking. So smoking is a huge risk factor, and I tell patients it's like putting gasoline on the fire. If you have this disease or have signs of this disease, if you were to be smoking, that certainly will enhance your risk of getting this disease.
Is that because it's a vascular?
Exactly. It's because it's a vascular process, and smoking certainly isn't good for that. Other risk factors include hypertension, high cholesterol, cardiovascular disease in general. There's an inflammatory component, and as this slide discusses too, hypoxia or oxidative stress, just meaning that there's some stress with lack of oxygen to the areas of the macula that then the response is this disease process. And there's probably other factors we're unaware of. And then the family history sort of ties into the genetics. So if you have somebody who's in the family that has the disease, that does put you at a higher risk of developing the disease. So it's a lot of the things that we're told to be careful of anyway in our health, like the blood pressure and the smoking and everything. Absolutely.
So it's kind of not new to us, as we get older. So, well, then we were going to talk about like symptoms, and I think that's when we were talking. I was talking to you beforehand about, you know, this is something we all want to be really kind of aware of. So let's talk about that.
Yeah, the classic symptoms really of macular degeneration is none, no symptoms
Yeah,
oftentimes.
that's,
so
unfortunate.
that's where it really ties in. It's important to have a
Yeah.
comprehensive eye exam with your ophthalmologist, and oftentimes a patient will have no symptoms, and there will be early signs of the disease, and then we can do certain things about that. But in patients that have dry macular degeneration, because the damage is rather subtle initially, the symptoms are rather subtle. They can be as subtle as just a little fine blurred vision, or maybe little difficulty with reading or seeing the TV or driving.
And you think that's just age?
And you do think it's age. A lot of times it is just age. A lot of times it's cataracts. But sometimes it can be this disease developing. So now the classic symptoms we associate with this disease really accompany the wet macular degeneration. So it's when someone develops the wet type, where these blood vessels start to grow in the center part of the retina and the macula. And when they do this, an analogy I like to give is they're like weeds in the garden. And so when they do this, then the patient may start to see some distortion in their central vision. Whether it be lines are all of a sudden distorted, wavy lines, or even just blurred central vision. And it can be it can be slow, but it can also be aggressive, where someone's first symptom may be a lot of vision loss, and that can mean that a blood vessel has grown and actually burst and bled into the macula. So, but the classic symptoms really are central distorted vision. Usually doesn't affect the peripheral vision. Central distortion or central blurred vision.
Yeah, well, it's good just to know it, just to be aware. I mean, as much as we and like we were saying, the best thing is get your exams.
It is. I see someone every day, or almost every day, that didn't recognize they actually had lost a significant amount of vision in one eye until they went into their regular eye exam, and the eye doctor closed one eye to check their vision. They went, oh my gosh, I can't see.
Yeah, you don't think.
And you don't necessarily recognize that on your day-to-day. You may have a better eye, and that eye's just compensated for the bad eye.
Right.
But you need to catch that early. So I do tell patients, even without the disease, if you're over the age of 50, it's probably a good habit just to every once in a while cover one eye and just kind of make sure that your vision is good in both and nothing new there. But an ocular exam with a comprehensive ophthalmologist annually after the age of 50 is prudent in recognizing it early.
Right, yeah. And our health plans allow for that. So, I don't think that there should be any problem.
Exactly.
With getting, and you do need authorization to go see an ophthalmologist for your annual eye exam.
Yes.
So a lot of times people aren't sure how to use that benefit, with their various insurances.
Right, and I'll clarify too, a lot of times patients will ask, well, are you an ophthalmologist, a retina specialist? So as a retina specialist, you're an ophthalmologist, so you do your ophthalmology training, and then it's just further subspecialty training in retina. But with Monarch and many plans, you need to first see the comprehensive ophthalmologist or general ophthalmologist, and then if they deem that a retina specialist is necessary, then that's when you get to me or our group.
Yeah. And and Monarch does send you to an ophthalmologist for the eye exam. A lot of people end up going to optometrists because they think that's what the health plan, and the health plan will pay for that, But not all medical groups will send a person to the ophthalmologist, which is because, like we were saying, they're going to maybe catch some of these things.
Yeah, the ophthalmologist is trained to better identify some of those risk factors that would put you at risk for disease like macular degeneration or other retinal diseases, in fact.
Exactly, some of the things that are going to happen as you get older.
Yeah.
Now, and the other thing is, it'll happen to both eyes at once all the time, or does it?
Yeah, that's a common question. So it is a disease that affects both eyes. It always starts in both eyes. It always starts dry at some point, even though someone's initial symptoms may be because of a blood vessel that's growing and they have a wet macular degeneration in one eye. If we had seen that patient a year before, we would have seen signs of the dry macular degeneration in both eyes. So it is a disease that affects both eyes, and initially it's dry, and then over time it may change to wet in one eye. If you do get wet in one eye, then the studies show that you have about a 40 to 50% chance over the next 5 to 10 years of developing wet in the other eye. But yes, it's a disease that affects both
Both
eyes.
eyes,
Initially
yeah.
dry.
Because you're always thinking, well, just because I hurt my right foot doesn't mean the left foot is going to,
right.
or something like that.
No, that's very true.
Yeah.
It tends to symptomatically affect patients asymmetrically, meaning that it's unusual for someone to have a sudden loss of central vision in both eyes.
Yeah.
So usually one eye gets affected with the wet, and that's what identifies the dry that was in probably that eye before it became wet.
Yeah.
And then hopefully it stays wet in just one eye, but as I mentioned, about 40 to 50% chance the next 5 to 10 years that the other eye gets wet as well.
Right. So, we got some clues there to be checking on.
Yes.
And we were talking already about how it's diagnosed. And more or less, it's diagnosed by your exams.
Yeah,
or these other tests you can do.
Yes, and there is great technology now that allows us to diagnose this disease earlier and faster and less invasive. So historically, when the patient saw a comprehensive ophthalmologist or an optometrist and they had the exam, they said, well, I think you have macular degeneration, let's send you to the retina specialist. And we can look in like we do today and clinically diagnose the dry macular degeneration and sometimes easily diagnose the wet with just an exam. But there are certain technologies and diagnostic tools that we have now that are imperative in really diagnosing it correctly and helping us treat it correctly. So specifically, well, historically, we would do a test called a fluorescein angiogram, and it's a dye test where we inject it into the vein of the hand or the arm and we take pictures. And the way that dye interacts with your macula, because as you're taking pictures, the dye gets to your retina within 8 to 10 seconds. And the way it interacts with your macula, that will help determine whether or not there's leaky blood vessels, how much damage there truly is, and would help dictate our treatment. Now, we still do that test, fluorescein angiography, but it's invasive. We do it less because we have a diagnostic tool called optical coherence tomography, or OCT, which is a diagnostic tool that basically utilizes ultrasound, but instead of sound waves, it uses light waves. And so it scans through your eye into the macula and into the retina, and it's basically taking these miniature microscopic slices of your macula to tell us, the physician, whether or not there's damage to those areas. And the beauty of this technology is it is done quickly, and it's literally just a patient puts their chin on a chin rest and we can snap a picture and we get that information. And now this diagnostic tool is out in both ophthalmology offices and optometry offices where they can recognize something's not right here. Let's get you to the retina specialist. And, so those are the clinical exam, dilated clinical exam. So lots of times I'll have patients come in to me and say, oh, I have to get my pupils dilated. And that's a requirement to get a full exam of the retina for me to be able to see back into the macula. A dilated exam, and then the fluorescein angiography sometimes we'll utilize, the OCT we'll utilize, and all of those together really gives us great information on what we need.
It's great to know.
It really is.
That you can really see all of that. Yeah, that's great. So I think we're going to skip along here with our slides, and we're going to get to how macular, here it is, the treatment. That's the part.
Great.
So once you've been diagnosed, then and what happens?
So boy, the treatment has evolved over the years, like many diseases, but we've made huge strides in the treatment of wet macular degeneration specifically in the last 10 years. I've been doing this long enough to see how it worked with patients when we didn't have the treatments that we have today, and that was pretty much guaranteed vision loss, and kind of our hands were tied and we couldn't do a lot. But historically, if you look at what we were able to do initially, years ago, the first treatment identified was thermal laser, and laser was identified as a way to basically destroy these blood vessels that are growing. So these blood vessels, to use the weed analogy, it would literally be just pulling the weeds out. And just the thing about that, though, is when you pull them out or when you destroy them with the laser, you actually cause collateral damage too. So you're not just destroying the blood vessels that are growing, you're also destroying the normal macular anatomy. And so although you were able to destroy the blood vessels, the vision wasn't great. In fact, the vision tended to get worse and even in some instances worse than it may have been with the natural course of the disease. Yeah.
Yeah.
But we did have good studies back then that showed on average, if you had the wet macular degeneration and had certain characteristics of the wet, thermal laser would provide you a better outcome than if you hadn't had treatment.
Right.
Still wasn't significantly better though. Then we moved forward a few more years, and then we had something called photodynamic therapy, which is basically great and interesting technology where we could inject a dye, and we still use this sometimes, where we inject a dye into someone's vein, like the fluorescein, but this dye actually has a preference for leaky blood vessels.
Huh. Isn't that something?
And when it gets into these leaky blood vessels, then we could activate that dye with a cold laser, and when we activated the dye, it would shut down that blood vessel. So that too was a little better efficacy than the laser, but it still had collateral damage. And so although that was another step forward in preserving vision a little bit at a little bit higher rate than the natural course and laser, it still wasn't great. And so then we really moved on to what we're using now today, which are these injections, these medicines that we actually inject into the eye. The first FDA approved injectable was something called Macugen, or pegabtinib up there.
Yeah.
And that had a preference for the leaky blood vessels as well. So to use the analogy of the weeds again, that was the weed killer. Just like if your weeds were growing in your garden, you could spray it and it actually wouldn't kill the grass, it would just kill the weeds.
Right. Yeah.
We found with subsequent studies that Avastin, Lucentis, and Eylea, which are the more recent 3 drugs, were more efficacious than the Macugen. So those are the 3 drugs we use right now. The generics are bevacizumab, ranibizumab, and aflibercept. I won't use those names anymore because they're tough to say, but that's basically Lucentis, Avastin, and Eylea. And those are the 3 drugs that we use today. And the way they work is we have found that the blood vessels that grow in this disease need food or fertilizer. And that fertilizer comes in the form of this protein called VEGF, vascular endothelial growth factor. This VEGF stimulates these blood vessels to grow, and they grow and grow and grow. When we inject this medicine, it actually takes away that protein, that VEGF protein, starves the blood vessels, and they actually involute.
Wow.
But as soon as the medicine wears off, the blood vessels come back because that VEGF comes back. Interestingly, patients always ask, well, how do you decide which medicine to use? And I heard that Avastin is a chemotherapy agent or something. And Avastin's not a chemotherapy agent, but it was approved, or is FDA approved, for the treatment of colon cancer.
Yeah.
And the reason why it's approved for that is tumors, specifically colon cancer tumors, do need a blood supply.
That's another, it works the same way.
Exactly. And so if you can starve the tumor by taking away its blood supply, you could help enhance the efficacy of eradicating the tumor.
Like, what was I thinking about with that one that they use on the face? I can't remember it now, but it was used for cosmetic, and then all of a sudden they were using it for a urinary problem.
Right. Yeah.
Because
exactly.
sometimes they work for all other things.
Absolutely, and that's and that's what we found is that. Although initially the studies, when you gave the Avastin through the veins, which is what you needed to do for colon cancer, it did get to the eye through the veins, but the side effects through the veins for the eye were too high. And that's where Phil Rosenfeld at Bascom Palmer Eye Institute figured out to maybe aliquot the Avastin in a little smaller dose and inject it into the eye. And then the studies also ensued from Genentech with Lucentis and then subsequently Regeneron with the Eylea that found that by injecting these medicines into the eye, we can, with 90% success now, we can slow the process down. We can't cure this disease, and hopefully one day we will. We can't cure it, but we can certainly slow its progression with these injections. And they are injections into the eye. Yeah,
and you're thinking about that isn't too pleasant.
Yeah, and I tell patients that 90% of the time the anxiety of the shot is worse than the shot itself. And like lots of treatments, there's a bell curve here in what you need for treatment. Some people require a shot every month for the rest of their life. That's one extreme. And on the far other extreme, a patient may need only 1 or 2 shots, and then they don't need a shot
They're
again.
okay for a while. Yeah.
Most people need treatment forever, just like if you had high blood pressure, if you had high cholesterol, diabetes. If you don't take your medicines, the disease is going to get worse. So if you develop the wet macular degeneration, then treating it with these can slow its progression.
Right. So we might, if under this condition, the treatment would be you'd be going back every so often for this and
see if the shot is necessary.
But it'll preserve your vision.
High chance of preserving the vision.
That's the whole.
It is important. I tell patients that if this is their vision here and we don't treat it, their vision will go like this. With treatment, it doesn't necessarily go like this. It actually still, over time, maybe gets a little worse than what it was when we started, but it's a lot better than it would have been if we hadn't treated.
Sure, that's very hopeful.
Yes, it is.
And going to the doctor's appointments is not the biggest deal in the world.
We try to make it efficient, and most people's biggest fear is losing vision. And if it means coming an hour or hour and a half a month,
it'll work. It'll work for most of us. Yeah, that's great. That's great to know. So, and then we've got this about vitamins.
Yeah, eye vitamins.
Yeah,
so
they could work, huh?
Yeah, well, with dry macular degeneration, we don't have a definitive treatment for it. But the National Eye Institute showed with a study called the Age-Related Eye Disease Study, and it was the second study, the most recent study, it showed that if you had this disease, intermediate or advanced macular degeneration, and you took vitamin C, vitamin E, zinc, lutein, and zeaxanthin in those amounts, you reduced the risk of your disease getting worse by about 25%. So in patients that have macular degeneration, specifically intermediate or more advanced than that, if you take this eye vitamin, you can reduce the risk of its progression. And when I say this eye vitamin, I mean these constituents. You can do them one by one, or you can actually get one that houses all of those.
They do have them. Huh?
And they have those, and those are over the counter.
Yeah.
And that's what we advise when they've been diagnosed correctly with the macular degenerative disease. By taking this eye vitamin, you reduce the risk of progression. It wasn't shown to be beneficial in people that didn't have the disease, and it wasn't shown to be beneficial if you had a family member with a disease. You say, oh gosh, my mom went blind, I'm going to take it before. It wasn't shown to be beneficial, but sometimes as a patient, you can understand if your parents went blind from this disease, it may be reasonable to consider it.
Right. So, well, we covered it. We covered these. These were the important questions.
Oh, great.
And I think this is very valuable information for everyone to know. So, thank you for joining us today. And I hope some of you call in to tell me if this was worthwhile for you, and that it was a lot of, maybe now when you go back to the retina specialist, you'll have some questions to ask.
That's right, exactly.
Since we're going to be seeing him so often, if this is what our situation is. Yeah, and we want to thank you for joining us today. For Senior Focus, and you can call me if you have any questions about today's show or anything else. And remember that I'm going to be at the Florence Sylvester Senior Center the first Tuesday of each month from 10 to 11. And we also have our other numbers up for customer service if you want to reach them for any of your questions. And thanks again for joining us for Senior Focus.
Thanks, Ben.